Hi, everyone. I'm Pat Camillo, aka Nona Nurse. In a recent article I posted on Substack, I talked about the stresses that nurses are experiencing in acute care. I know some of this because I've been mentoring nurses for years as they were going to school and during their coursework. And the stresses they are telling me about in acute care are significant, and that's where most of them are working. They're being told to build more resilience, have more reliable coping skills, create a better work-life balance, and perhaps even seek counseling. But here's the problem. When the focus is on burnout, instead of chronic system-produced stress, institutions and even sometimes nursing itself end up blaming the nurse, whether that's intentional and hopefully mostly unintentional. But that's what it does at the end of the day. I believe we need to shift the focus back on the institutions creating this stress. Because here's the thing, this is not a new issue. And today in this video, I want to share my personal experiences, the stresses I had to deal with and how it felt when I was first practicing in acute care back in 1974. Okay, so let's get to it. I was a new graduate in 1974 from a 2-year community college program. I had excellent teachers. They were mostly graduates from Columbia because I was in upstate New York. And they used to tell us that, yes, we didn't have all the clinical experience we needed yet, but because we understood something, we should be able to do it. That was very optimistic, and sometimes that worked, but a lot of times it didn't. But I was a new graduate, and I was enthusiastic, and I was raring to go, even though I didn't know how to hang an IV yet. So I got a job in a hospital in New York City, which is the city where I was born and grew up. So I felt very comfortable there. It was, again, 1974. After the orientation session, I was assigned to a 45-bed male ward. I think they thought that since I was a New Yorker that I should be able to handle that. Mostly it was okay, but not entirely true. My roommate, on the other hand, was born and raised in the country, and she got sent over to the other wing of the hospital. Actually, I think she was on a unit that dealt with plastic surgery. So we had very different, strange stories to share at the end of our shifts, and very different experiences. So on this 45-bed male ward, there were about 14 beds in the front room, which was closest to the nurse's station. These were for the sickest, and they were one bed right after the other in this one very large room. And they were there because they were never sent to the ICU. They weren't privileged to go to the ICU. So we basically had a med-surg unit with a mini ICU unit on it. And with nurses like me who had very little experience. Most of these male patients had a history at least, or were alcoholics. So when they would get admitted, they were often seizing because they were coming in off the street. We used to joke that at the beginning of the month, the residents must have went out with their nets because we would get a whole bunch of new admissions that they could work with. Good learning experiences for them, and probably a good opportunity for these individuals to get some health care. When they came in, they were usually, each patient was assigned 2 nurses, not 1. And the reason for that was because they were in such bad shape. Not only, in terms of their medical needs, but they were really grungy. We would put on a gown and put a mask and gloves and a cap on because their hair would be matted and full of lice. And so one of the nurses would be washing them down with something like Quell. I can't remember what it was. And the other nurse would be suctioning him to make sure the airway stayed open because he would be seizing. Stressful, a little stressful. In fact, some of them came in with ulcers on their legs that had not been treated in forever, and so there were maggots on them. Stressful. I remember one admission especially sad was a teenager, a male teenager who was diagnosed with cirrhosis. Really unusual for a teenager, but kind of reflects the kind of poor health and poor health care these individuals were getting back then. There was a lot of interesting dementias that we would see. Korsakoff's was one that came from a thiamine deficiency, very common in alcoholics. In fact, one of the things we did on the admission was to immediately shoot him up with thiamine. The other really stressful medical condition that would appear were these esophageal varices. Now, the way they were managed back then, very different, I'm sure, today. But what we did then, as they were actively bleeding, they had a mask, looked like a catcher's mask, put on, and what I believe was called a Blakemore tube was inserted, and a nurse would stay by the bedside with some iced saline, and I believe there was some medication put in it to try and constrict and stop the bleeding. Sometimes for hours, we would stand there irrigating, fluid in, blood out. Very stressful. Not a lot of help, just one nurse. I often was just the only nurse standing there doing this. In fact, one time there was an aide that was walking by and my pan was so bloodied that I needed to have it emptied and refilled. And I asked if she would do that. And she turned to me and she said, "That's not in my union contract." Stressful. There were overdoses right on the unit because people would come in, their friends would come in and shoot them up in the IV. You could be assigned a patient and suddenly they're crashing and you have no idea what happened. There were attempted suicides and successful ones as well. One patient I remember jumped out the window and landed on the emergency room roof. The saddest one was someone from Mexico who was diagnosed with a tapeworm in his brain. And I think that was just more than he could handle. So he used the bars that separated the beds and hung himself. We saw a lot of syphilis on this unit, second and tertiary stages. These patients would receive procaine penicillin, which was this really viscous white penicillin that required a beveled needle and a very large needle at that, because it had to go deep into the muscle. A little bit challenging because most of these patients were pretty emaciated and malnourished. So finding a muscle even was challenging. The other issue that added to this stressful environment was that it was the early AIDS epidemic. And at the time, there was in New York City on top of it, there wasn't a really good understanding of how it spread. So there was this constant underlying fear of getting stuck with a needle. And in fact, several nurses did and needed to have prophylactic treatment within 48 hours. We also saw quite a bit of TB. These patients would be in single rooms at the other end of the hall with, I believe it was some form of ultraviolet light to try and reduce the bacteria in the room. But sometimes we had patients who didn't want to stay in their room. And when they came out, they could come out of the room if they wore a mask. So one night, I was working, and my partner who was working with me, the other nurse, had gone off on a break. And I think it was around 3 or 4 a.m. One patient who had TB came out of his room without his mask on. So I gingerly asked him if he would please put the mask on because, it's important to stop the spread of this disease. And I used all of my therapeutic language that I could, but he wasn't having it. So he got frustrated and he pushed me up against the wall. And luckily, where that occurred was sort of parallel to the hallway that was next to it. And way down at the end of that hallway was a young resident. I can still picture him, looked like a little Irish guy because he had reddish blonde hair, very pale skin. And he came down the hall and said, "Is there a problem here?" And the patient looked at him and I guess was a little intimidated, although hard to imagine because he wasn't really a sort of knight in shining armor. But he had a respect, clearly, that made him go back down to his room. The resident asked if I should maybe write an incident report, and I just didn't want to, and I didn't. I was pretty shook up, as you can imagine. I've been in difficult situations. I did grow up in New York City, but it was not something I expected in this setting. So that ended my shift, and I went home, but it stayed with me to the point where I finally thought, I can't do this anymore. The constant daily chronic stress, because we were short-staffed, we were overworked, we would often stay late. One way that they were trying to help mitigate some of this stress was they had what was called liver rounds, I guess on a Friday evening, I can't remember. And liver rounds was when you went up to the roof and you had a drink. It didn't seem like the answer to me. So I eventually decided I needed to leave. It was just unsustainable. So yeah, I know a little bit about stress in acute care settings. So where did I go next? I applied for a job as far away from the city as possible in upstate New York at a tertiary center's NICU. Now, that was pretty dramatic. It was a complete turnaround from what I was doing. Although, after the 9 months, I was really good at everything. I mean, all my clinical skills in that unit were honed. So, yeah. Although they did one evening, they sent me down to the female ward where there were a large number of prostitutes. And I had to insert a catheter into one woman, and I had to call my supervisor because I had never done it. I had no idea. But in terms of everything else, I nailed everything. So I felt pretty confident in my abilities. So the NICU, I had to do a lot of studying, learning. Everything was different. Meds were different. Dosages were different. Equipment that was being used, these little tiny babies who you never heard cry, who never made a sound. It felt more like I was working in a lab sometimes. But what humanized it certainly were the families and what they were going through. So there wasn't the same stress as what I experienced in the ward. It was a different kind of stress. I was assigned evenings eventually, where I was the only RN for about 30-something infants. Pretty amazing. There was a staff of LPNs, and that was great. They were very good at what they did. I would generally start a medication and they would finish it because most of the meds were given via the umbilical line. These were really fragile babies. Most had some sort of respiratory support, either intubated or on CPAP. And also during those years, we had the first cardiac open heart take place. I was there for 3 years. So saying 75, 76, 77, maybe till 78. And so because it was so new, nobody had done this with these babies before. The cardiologists were very involved. The cardiac surgeons were very involved. And I'm sure they were also very stressed because they were kind of pricks when in dealing with the nurses. We had to also go down to the OR and be there during the surgery because no one knew how to even manage these tiny ones in the surgical suite. They had no idea about the impact of being cold on their metabolic system. So that was pretty stressful. The other thing that added to our stress there was that I would need to go out on a transport to pick up a baby. Now, this was in upstate New York, so as a regional center, we included some rural communities in Vermont. And so, again, on the evening, I would often be the only RN. I would need to leave my shift, and then, a supervisor would technically be in charge. Of course, she didn't do anything, so there was that. Because I would leave, and when I returned several hours later, I would need to catch up with the meds, with the everything, the charting, the checking on everything. And the transport itself was often stressful. This was not by helicopter, this was by ambulance, so it took a while. And some of the babies were really sick. I sometimes would find a preemie in some of these very rural settings where, honestly, the nurses didn't know very much, or even the doctors, about what to do in these situations. So I would find some of these preemies just laying on cold tables because they didn't even have the right incubators to put them in. I remember one full-term baby who had an omphalocele, fairly straightforward, manageable to transport. But, the parents were incredibly distraught because this would take the baby, their brand new baby, many hours away from their home. And so their stress also increased my own in trying to help them. In the NICU itself, because these babies had a lot of apneic spells, it's not unusual to hear the alarms go off, sometimes a couple of times an hour, depending on the infant and how unstable they were. And again, there were many stressed and often grieving parents that we would counsel and be there for. Some of these babies simply did not have survivable conditions, even though they were still living. Babies with anencephaly or with some forms of trisomy. There was a lot of emotional weight in this unit. Very stressful. Could have been better with sufficient staffing, because that simply added to everything. But there never was. Sometimes they would recruit nurses from the adult ICU to have them work. And okay, that was better, but they knew nothing about these little ones and what they needed. So, yeah, I loved that job, but I was exhausted, both physically and emotionally. So what happened next? So during those years, there was a push for nurses to get their baccalaureate degree. I thought I better get on board here, but I needed to work. I was self-supporting. I was single, but I needed to support myself. There was no easy way to do this. There were no online programs. But I did manage to find a program out of Skidmore College that was called University Without Walls. I didn't have to attend any classes, but I would have to produce all the same work and take all the same exams, and also have all the same clinical hours that were required in their BS program. None of what I did at the community college level was acceptable to them. So it was a lot. And I needed to figure out what to do. I knew I couldn't stay in the NICU and do it. It just would be impossible. I wish more nurses today came to that conclusion, because they're putting themselves at serious risk for health problems with the stress they're imposing on themselves. But I luckily found a way that I could make some money, enough to live on, not enough to buy a new car, but enough to get by, at least for the 2 years I figured it would take me. And it was within the same hospital, where they set up an agency, sort of an agency for what would be considered private duty nursing, but not in the way you would think in terms of fancy private duty nursing. This was private duty, one-to-one care for a patient who could no longer stay in the ICU, had no place else to go, and was a DNR, and was sick enough so that it was known they would probably die within a few weeks. So I would be assigned a patient, and I would stay with that patient until they died. It gave me a lot of space to work on, because once I finished their morning care, most of these patients were not sitting up and chatting with you. They were either in a coma or in pretty bad shape. But you were just there to be supportive. And, it was actually beautiful. Certainly nothing you would ever find today. So in that sense, that was amazing. They had someone with them. And I was present when they died, many of them. It was difficult not because of the physical work required, but because of the amount of time I would spend with each person. There was an emotional connection that developed. I share some of these stories in my memoir. And actually, I remember one in particular, Henrietta, who I'll never forget. I could still see her. She died in my arms. And I'll never forget her. So the emotional work in that setting was the most stressful, but also the most satisfying. Okay, so where did that take me? And I won't get into where I went next. You'll have to stay tuned for my next episode. But there is something else I would like to add, because I did go online and look around to see if I could find any reflections on those years in the 70s. And I found something interesting in a publication produced by the New England Journal. And it was an interview with Charles Stokes. He was a former chief executive officer for Memorial Hermann Health System in Houston. And he shared the following. So I will read this, but encourage you, and I will share the link to read the entire interview. But I'm just going to read an excerpt to you because I thought, yeah, he's validating what I'm saying. Back to 1979, when I was assistant director of nurses, he says, at University of Mississippi Medical Center in Jackson. I had responsibility for the critical care unit at the university at the time, and we were a trauma center for the state of Mississippi. We ran a critical care unit 24 hours, 7 days a week, and we were always busy. I can truthfully say that since 1979, I have been recruiting nurses for the last 44 years of my career, and it has never stopped. In 1979, we were recruiting nurses from the Philippines, from Canada, from England, and we were doing the same thing that people are doing today. We were offering sign-on bonuses. We were leasing cars. We were paying federal or referral incentives to get nurses to come to University Medical Center. When I left nursing and got into becoming a healthcare executive after graduate school, I was in 8 different organizations in my career. And in all 8 organizations for 44 years, I've never gotten to a point where we had enough nurses in our organization to make a difference. And I especially like this last sentence I'm going to share. He says organizations have to make sure that they are providing the environment that makes people want to continue to come into nursing. So yeah, it was like this. Now let's see, over 50 years ago. What you're experiencing today is not new. Then I turned into looking at burnout and to see, was that something a word we used back in the 70s? Because I don't remember it. Interestingly, the first time the term was used in clinical settings was during the 70s. And this is also a link that I will share below, because I'm just going to share some of what matches what we're talking about here. Historically, burnout, an informal, everyday term that was used to describe the devastating effects of chronic drug abuse. But then there was a psychologist who provided services at St. Mark's Free Clinic in the East Village in New York City. He noticed that the volunteers gradually felt emotionally depleted. They had less motivation and a reduced commitment. And that's where the term burnout got started in reference to healthcare providers. So it came from psychology. And I find that especially interesting because from that point forward, there were tests that were devised to measure, to assess a person's burnout, to assess the presence of burnout. But there wasn't a whole lot of thought given to the context or the circumstances that generated that burnout. What was that? So again, I refer you to that Substack article where I talk about how different chronic stress and burnout are. Chronic stress will lead to burnout. So they are not the same. And yes, now you know that I know a little bit about the stress you're experiencing in acute care nursing. And the really important point that I want to emphasize again and again is that this is not new. In fact, I had the foresight, and I don't know why, because I was in my 20s. I don't know what I was thinking. But I took pictures of that ward, and I kept them all these years. I guess because it was such a traumatic experience for me those 9 months. And those pictures reveal a lot. I don't have many, but you could see what a ward looked like. And I have them posted on my website in a section in the tab that says archives. So take a look and you'll see what I mean. Now, where do we go from here? What do we do about this? Right? Because that's the bottom line. All right. I see that that nurses are experiencing chronic stress today. I looked at the causes. These are my 2 articles on Substack. And here with my video, I'm sharing the lived experience of what that is. But now we need to really talk about what to do about it. Because if we keep calling it burnout, we'll keep focusing on the nurse. But if we begin to see it as a system-driven stress, then the responsibility begins to shift. And that's where I'm going to go next. But until then, I'm Nona Nurse, sharing a little warmth and wisdom that I hope you pass on.